regarding gastritis. It is a histological diagnosis. This has to be noted because it is not the erythema that is seen during endoscopy. It is a histological diagnosis where you have to demonstrate the infiltration of mucosa with some cells. In acute gastritis, it will be neutrophil predominant. In chronic gastritis, it will be lymphocyte predominance. So, it is a histologically documented inflammation of the gastric mucosa. It is broadly classified into acute gastritis and chronic gastritis and some miscellaneous form of gastritis. Acute gastritis, it is mostly due to H. pylori infection. Patient will present to us with epigastric pain, nausea and vomiting. If not properly treated, this can go in for chronic gastritis, which in turn can go in for gastric carcinoma. The histology will typically show neutrophil infiltrate because it is acute neutrophil infiltrates. And there is a peculiar form of gastritis called as phlegmonous gastritis, which is nothing but bacterial infection other than H. pylori. The commonest organisms are Staphylococcus, Streptococcus, E. coli and Proteus. And the common predisposing condition to this phlegmonous gastritis are the polypectomy and Indian ink injection in the mucosa of stomach. Two other specific form of infections called as cytomegalovirus gastritis and herpes gastritis are common in immunocompromised state. This is the classification of gastritis. Table column given in Harrison. Acute gastritis, it could be due to H. pylori infection or the other infection organisms like phlegmonous, mycobacterial, syphilitic, viral, parasitic and fungal. Chronic atrophic gastritis, it is divided into type A and type B. Type A is autoimmune, which is body predominant, and type B is H. pylori related and antral predominant, and other miscellaneous forms like lymphocytic, eosinophilic and Russell body, sarcoidosis and Crohn's disease. Chronic gastritis, here the infiltrates will be predominantly showing lymphocytes, and there are three phases actually. First phase is the superficial gastritis. If not treated at this stage, it will go in for atrophic gastritis and which will lead to gastric atrophy. In superficial gastritis, the inflammation is limited to the mucosa, lamina propria, and there is no glandular destruction. In atrophic gastritis, there is destruction of glands and the inflammation further goes in deeper. And the third stage is gastric atrophy, where there will be no glands, no infiltrates. And at this point you can see intestinal metaplasia, and this metaplasia can be a forerunner of CA. And type A, the chronic gastritis is broadly classified into type A and type B. Type A, it is body predominant, which is mostly due to autoimmune, and type B, it is antral predominant and is mediated by H. pylori infections. Type A is less common form and it spares the antrum. Antrum is a region where you have that G cells which secretes gastrin. These patients have concomitant pernicious anemia, which leads to B12 deficiency. Hence, this is also called as autoimmune gastritis. So, you can demonstrate antibodies in the form of anti-patent cell antibody and anti-intrinsic factor antibody are more specific to type A gastritis. Also, HLA-B8 and DR3 are associated with type A gastritis. Since the patient has achlorohydria, the patient also develops B12 deficiency. The achlorohydria combined with antral sparing will result in hypergastrinemia because achlorohydria, the negative feedback is lost and hence gastrin production will be more. Gastrin is produced by the antral cells. Here antrum is spared, so we will have hypergastrinemia. Type B gastritis, it is a most common form. Here it is antral predominant, which is mainly mediated by H. pylori infection. This form of type B gastritis is seen in 100% of individuals over 70 years. The incidence increases with age and it comes to nearly 100% above 70 years of age. Ultimately, it results in gastric atrophy and gastric carcinoma can occur. This bacteria is one which can predispose to malignancy. The other malignancies that can be associated with H. pylori infection are low-grade B-cell lymphoma and multi lymphoma, mucosa associated lymphoid tissue lymphoma. You have to treat the H. pylori infections, and treating this H. pylori infection can cause regression of the low-grade lymphoma. After the treatment, the tumor may take around 1 year to regress, and the patient has to be serially followed up. If the tumor does not shrink, then one has to consider that the patient has gone in to develop high-grade lymphoma, and it has to be managed accordingly. Management Rather than going for a specific form of treatment, the sequelae has to be addressed either in the form of B12 deficiency or to supplement the patient with B12 deficiency apart from treating H. pylori infections.